Lower blood pressure protects the brain. Lower blood pressure destroys the brain. Both statements are true, and the variable that determines which one applies to you has never been measured by any blood pressure prescription you have received. For 50 years, cardiovascular medicine enforced a clean universal rule: drive the number down. Below 120 systolic, the lower the safer. You have taken this medication or you know someone who does. Approximately half of adults over 65 in the developed world take at least one antihypertensive drug. The rule they were prescribed under was derived from large population studies of robust middle-aged adults, people with strong hearts, elastic arteries, and enough muscle mass to walk briskly across a parking lot. For that population, the rule worked. Lower pressure meant fewer strokes, fewer heart attacks, fewer cardiovascular deaths. The evidence was overwhelming. The guideline became gospel. Physical frailty, the one variable no blood pressure prescription has ever required, was measured in a study of over 6,000 adults, average age 75, followed for a median of 9 years. Smith and colleagues at the University of North Carolina published the results in Neurology on June 10, 2026. Strong grip, fast walking speed, preserved muscle mass, sustained energy throughout the day, stable body weight. The participants the researchers classified as robust. These are the adults who carry their own groceries, climb stairs without pausing, open jars without thinking about the effort. Weak grip, slow gait, significant muscle loss, chronic fatigue, unintentional weight loss. The participants classified as frail. These are the adults who rest after climbing a single flight, who avoid carrying heavy bags, who notice that tasks requiring physical effort have quietly become tasks requiring planning and assistance. The blood pressure data split on that single variable with a clarity that challenges the universal target. In robust participants, higher blood pressure was associated with higher dementia risk, exactly as 50 years of guidelines predicted. In frail participants, higher blood pressure was associated with lower dementia risk. The relationship reversed: matched age group, identical medication classes, equivalent monitoring protocol. Opposite long-term cognitive outcomes determined by whether the body receiving the prescription had enough muscle to tolerate the pressure it was being given. 30% of those with frailty or pre-frailty developed dementia during the 9-year follow-up. 16% of robust participants did. The frail participants who maintained higher blood pressure, the ones whose physicians had not aggressively lowered the number, showed lower dementia rates than frail participants whose pressure was driven to the universal target. The robust participants showed the opposite: higher pressure, higher dementia risk. The same number on the monitor meant protection for one body and harm for another. The dizziness when you stand, the brief darkening of vision before the world stabilizes, is the body's upward pumping system catching up. Think of it as minimum water pressure in a building's plumbing. The heart pumps blood upward against gravity to the brain. The top floor of a building approximately 1.7 meters tall, with the pump in the basement and the most important tenant at the top. As long as the pressure is high enough, blood reaches the top floor and the brain receives the oxygen it needs. The system adjusts automatically. When you stand up and gravity pulls blood downward toward the legs, the arteries constrict to maintain upward pressure. When you lie down and gravity is no longer a factor, the arteries relax. The adjustment is continuous, automatic, and invisible, unless it falls behind. In a young body with elastic arteries, pipes that flex and respond within a fraction of a second, the adjustment is seamless. You stand, the arteries narrow their diameter within 200 milliseconds. The pressure head adjusts, blood reaches the brain without interruption. The elastic walls absorb the pressure wave from each heartbeat, expand slightly to store energy, and recoil between beats to push blood forward during diastole. The system is self-correcting across a wide range of body positions and physical demands. In an older body with stiff arteries, pipes that have lost their elasticity through decades of calcification, collagen cross-linking, and smooth muscle remodeling, the adjustment takes longer. You can feel the stiffness indirectly. The pulse in your wrist is sharper and more abrupt than it was at 30. A compliant artery absorbs the pressure wave and returns it gently. A stiff artery transmits it like a hammer blow through rigid plumbing. The sharp pulse you feel at the wrist is that undamped wave arriving at the cerebral vasculature. The walls cannot constrict or dilate quickly. The pressure wave from each heartbeat is not absorbed. It is transmitted at full amplitude through rigid tubes, and the recoil between beats is diminished because stiff walls do not store and release energy the way elastic walls do. In a compliance system, the artery acts as a second pump. The wall expands during systole, stores elastic energy, and releases it during diastole to push blood forward between heartbeats. The brain receives continuous flow, systolic push from the heart, diastolic push from the elastic recoil. Stiffen the artery and the diastolic push vanishes. The brain receives pulsatile flow instead of continuous flow, near stagnation beats. The hesitation you feel as dizziness is the lag between the demand for upward flow and the stiff system's delayed response. Cerebral autoregulation, as Lipsitz characterized in the Journal of the American Medical Association, is the technical name for this upward pumping adjustment system, the brain's ability to maintain constant blood flow regardless of what the rest of the body is doing. And the critical number within that system is the minimum pressure the stiff pipes need to deliver blood to the top floor, the autoregulatory floor. In a 50-year-old with compliant arteries, the floor is low. The flexible pipes can dilate and constrict efficiently, maintaining cerebral flow even at relatively low systemic pressures. In a 75-year-old with stiff arteries, the floor has risen. The rigid pipes need more driving pressure to deliver the same flow because they have lost the ability to actively assist circulation through elastic recoil. Walking discussion described how stiff arteries transmit undamped pressure waves to the brain, the hydraulic hammering that damages delicate cerebral vessels. The opposite problem is equally dangerous. Stiff arteries also fail to dilate when pressure drops. The damage runs in both directions. Too much pressure and the undamped waves hammer the delicate cerebral vessels. The hydraulic shock that the elastic Windkessel function would have absorbed in a younger system. Too little pressure, and the blood cannot reach the top floor through rigid pipes that can no longer actively assist circulation. The safe range between too much and too little, the autoregulatory window, narrows arteries stiffen. A 50-year-old with compliant arteries might have an autoregulatory window spanning from 60 to 160 millimeters of mercury systolic, a 100-point range within which the brain receives constant flow. A 75-year-old with stiff arteries might have a window spanning from 90 to 140, a 50-point range. Half the room for medication to lower pressure without dropping below the floor. Physician prescribing the medication does not know where the patient's autoregulatory floor sits. No standard clinical test measures it. The blood pressure cuff measures systemic pressure, the number at the pump. It does not measure cerebral perfusion, the flow at the top floor. The physician aims for a target derived from population data. The individual patient's floor, determined by their specific degree of arterial stiffness, their specific cerebral vascular geometry, their specific peripheral pump capacity, is unknown. Your brain weighs approximately 2% of your body mass. It consumes approximately 20% of your total oxygen. The organ that houses your identity, your memory, your ability to recognize your grandchildren's faces, that organ demands 10 times its proportional share of the body's oxygen supply every second of every day. Cerebral autoregulation exists because the brain cannot tolerate what every other organ in the body handles routinely. Your skeletal muscles can function anaerobically for minutes. The burning you feel during intense exercise is the muscles switching to oxygen-independent metabolism. Your kidneys can reduce filtration during low-flow states and resume when flow returns. Your gut can slow digestion during exercise and restart afterward. The brain has no such fallback. It runs exclusively on aerobic metabolism, glucose plus oxygen, every second without interruption. It has no anaerobic reserve. It cannot pause and restart. It cannot reduce its metabolic rate below a minimum threshold without neurons beginning to malfunction. 4 minutes without oxygen and neurons begin dying. 10 minutes and the damage is catastrophic. The system that maintains flow to the brain is not a convenience. It is the non-negotiable engineering constraint the entire cardiovascular system is built around. When medication lowers systemic pressure below the autoregulatory floor in a body with stiff arteries, the deepest capillary beds of the cerebral cortex lose perfusion first, not a stroke, not a sudden catastrophic blockage that produces obvious symptoms and sends the person to an emergency department. Something quieter. A chronic low-grade oxygen deficit across millions of microscopic vessels in the watershed zones. the regions furthest from the major cerebral arteries where blood arrives last and leaves first when pressure drops. Now picture a garden during a drought. The plants nearest the water source survive. The plants at the far edges of the irrigation system, where the pipes are narrowest, where the pressure is lowest, where the water arrives last, brown first. Not because the water stopped entirely, but because the pressure dropped below what the longest, narrowest pipes need to deliver flow to the furthest beds. The neurons in the watershed zones of the brain are the far edge plants. These watershed zones sit at the boundaries between the territories supplied by the major cerebral arteries. The anterior, middle, and posterior cerebral arteries each supply their own region, and the watershed zones occupy the borders between regions where the perfusion pressure from both adjacent arteries is at its lowest. When systemic pressure drops below the autoregulatory floor, these border zones lose perfusion first. The neurons there receive insufficient oxygen and glucose for normal metabolism. They do not die immediately. They enter a state of quiet metabolic depression. Synaptic activity slows. Protein synthesis, the molecular process that maintains the structural integrity of synaptic connections, becomes impaired. Waste products that normal blood flow would carry away accumulate in the interstitial space. The neurons are alive but operating below their functional capacity, present but not fully participating in the neural networks that produce cognition. The watershed zones are not random locations. They include regions of the prefrontal cortex responsible for executive function, planning, decision-making, the ability to hold multiple pieces of information in working memory simultaneously. They include regions adjacent to the hippocampus, the structure that converts short-term memories into long-term storage. The cognitive functions that decline first in watershed microischemia are the functions housed in the zones that lose perfusion first: planning, multitasking, word retrieval, and recent memory formation. Medical terminology for this state is microischemia, microscopic areas of insufficient blood flow, too small to appear on a standard brain scan, too widespread to ignore in their cumulative effect across millions of neurons. Cognitive symptoms of watershed microischemia are the symptoms most people attribute to normal aging. The word that was on the tip of the tongue arrives less reliably. The name of a person met last week requires a moment of searching that it never required before. The driving route to a familiar destination demands conscious navigation where it was once automatic. The processing speed that once allowed effortless multitasking, listening to a conversation while monitoring traffic, following a recipe while answering a question, slows enough that tasks requiring divided attention become subtly harder. The ability to follow a complex conversation, tracking 3 people speaking in turn, diminishes so gradually that the person attributes the difficulty to the speakers rather than to their own processing. The doctor sees the reading, 118/72, and records it as excellent. The brain behind that excellent number is experiencing a drought. No blood pressure reading can detect. You know the paradox and the mechanism. Stiff arteries, a risen autoregulatory floor, medication pushing pressure below that floor, and the slow oxygen deficit that follows. The question shifts from what happens when pressure drops too low to why the body raised the pressure in the first place. Well, the evening I traced the cascade backward from the brain to the muscles. The frailty paradox stopped being a paradox and became an Angerine theorem. The body did not raise blood pressure randomly. The body raised it because the peripheral pump system that assists the heart had been dismantled by muscle loss, and the heart had to compensate alone. Skeletal muscle is a distributed cardiovascular pump. Every skeletal muscle contraction compresses the blood vessels running through it, pushing blood toward the heart, assisting venous return, maintaining the pressure head the cardiovascular system needs to function. The calf pump is one component of this distributed network. The quadriceps, the gluteal muscles, the muscles of the trunk and arms, every contraction contributes to the total pumping capacity. You do not feel this contribution because it is distributed across every movement of every day. Standing from a chair compresses the venous beds of the thighs. Walking compresses the calf veins with each stride. Carrying a bag of groceries compresses the forearm vessels. Climbing stairs compresses the gluteal and quadriceps vasculature. The contribution from any single contraction is small. The aggregate contribution from a body with 40 kilograms of skeletal muscle contracting thousands of times per day is substantial, a distributed pump network generating enough auxiliary pressure to reduce the workload on the heart by a measurable fraction. Person who walks daily, carries loads, climbs stairs, and uses their body as the physical instrument it evolved to be. Maintains this distributed network. The person who sits for 10 hours, drives instead of walks, uses lifts instead of stairs, and outsources every physical task to a machine loses it progressively muscle mass at the sarcopenia rate, compounding silently, the peripheral pumps dismantling while the heart recalibrates upward to compensate for each lost booster. When sarcopenia removes muscle mass, approximately 1 to 2% per year after 50 in sedentary adults, the sarcopenia rate, compounding across decades until a 75-year-old may have lost 30 to 40% of their peak muscle mass, the peripheral pump network degrades progressively. The calf muscles that compress the deep veins with each walking stride produce less force per contraction. The quadriceps that assisted venous return during every sit to stand generate weaker compression. The gluteal muscles, the trunk stabilizers, the muscles of the arms and shoulders, each loss removes another booster pump from the distributed network. The heart loses its assistant system. Imagine a central water pump designed to work with 10 auxiliary booster pumps distributed along the pipe network. Remove 5 boosters. The central pump must increase its output to maintain the same pressure at the endpoints. The endpoints being the capillary beds of every organ, with the brain's bed sitting at the highest point and demanding the most consistent pressure. Remove 8 boosters. The central pump is working near maximum capacity. The pressure at the central pump's output, measured by the blood pressure cuff as systemic blood pressure rises. The central pump is working harder, generating more pressure per beat, contracting more forcefully, driving blood through a system it was designed to share with 10 auxiliary booster pumps that no longer exist. Compensation is precise. The body does not raise pressure randomly or excessively. The baroreceptors, pressure sensors in the carotid arteries and aortic arch, continuously measure cerebral perfusion pressure and adjust cardiac output and vascular tone to maintain it. When the peripheral pumps were contributing, the baroreceptors calibrated to a systemic pressure that, combined with peripheral assistance, delivered adequate cerebral flow. When the peripheral pumps disappear through sarcopenia, the baroreceptors recalibrate upward, sensing that the cerebral perfusion at the old pressure level is no longer adequate and adjusting the cardiac output set point upward to compensate. The recalibration is gradual. Blood pressure rises over months and years as muscle mass declines over the same period. The physician who sees the rising number at annual visits is watching the compensation develop in real time. The elevated blood pressure in a frail 75-year-old is not a disease state in the way a 50-year-old's elevated pressure would be. It is the cardiovascular system's recalibrated response to a structural change in the body's pump architecture. The body is engineering a solution to a structural problem, and the solution requires higher driving pressure because the assistance that used to reduce the required pressure is no longer there. And then the medication arrives and the physician sees the elevated number against a guideline that says lower it. The prescription does what prescriptions do. It reduces the pressure. Within days or weeks, the number on the cuff drops. The pharmacology is reliable. ACE inhibitors, calcium channel blockers, diuretics, each class reducing pressure through a different mechanism, each mechanism effective and predictable at lowering the number the cardiovascular guidelines require the physician to achieve. 150 becomes 130. 150 becomes 130. 130 becomes 110. The physician is satisfied. The number is approaching target. The patient may notice nothing, or they may notice something subtle, a moment of unsteadiness when rising from a chair, a need to pause at the top of a staircase, a sensation of lightheadedness in the morning that clears after a few minutes of being upright. These symptoms, orthostatic symptoms, the clinical term, are the autoregulatory system signaling that the pressure is approaching its floor. The symptoms are often reported at the next appointment. They are often attributed to the adjustment period. They often resolve not because the autoregulation recovered, but because the brain adapted to reduced flow by reducing its metabolic expectations. The adaptation is the danger. The symptoms were the warning, the autoregulatory system signaling that the floor was close. When the symptoms resolve without the pressure being adjusted upward, it means the brain stopped protesting the shortage and began operating within it. The neurons in the watershed zones did not receive more oxygen. They reduced their demand for it. downregulating synaptic activity, slowing protein turnover, entering the metabolic depression that produces the cognitive changes the person will notice months later and attribute to aging. The compensation is removed. The structural problem remains. The brain, sitting at the highest point of a closed hydraulic system, powered by a single central pump that just lost its prescription to compensate, receives less blood. The reduction is not uniform across the brain. The large cerebral arteries near the circle of Willis maintain adequate flow because they are closest to the pump. The medium arterioles maintain reduced but functional flow. The deepest capillary beds in the watershed zones, the microscopic vessels at the farthest reaches of the cerebral vascular tree, are the first to lose perfusion. The brain does not go dark all at once. It dims from the edges inward, the way a city experiencing a power shortage loses its suburbs before its center. The outer boroughs lose power first. The central grid holds longest. The person experiencing the dimming does not feel neurons going offline. They feel the cumulative effect weeks and months later, in cognitive tasks that were once effortless and are now slightly harder, in attention that was once sustained and now wanders, in recall that was once instant and now requires searching. The autoregulatory floor that had already risen because of arterial stiffness is now being approached from above by a pressure that medication is actively pushing downward. The floor and the falling pressure converge, and when they meet, the watershed zones begin their slow drought. Self-reinforcing cascade maps as a single chain. Sedentary lifestyle produces sarcopenia. Sarcopenia removes peripheral pump capacity. The heart compensates by raising systemic pressure. The physician lowers the compensatory pressure to a universal target derived from robust populations. Cerebral autoregulation cannot compensate through stiff arteries. Chronic microischemia begins in the watershed zones. Cognitive decline reduces mobility. Reduced mobility accelerates sarcopenia, and further sarcopenia removes more pump capacity. The heart attempts to compensate again, but now the medication prevents the compensation. The cascade tightens with each cycle. The person who entered the cascade at 70 with mild sarcopenia and a blood pressure target of 120 may exit it at 78 with severe sarcopenia, significant cognitive decline, and a blood pressure target that has been protecting a number on a chart while the brain behind the number deteriorated. The physician saw improving readings at every visit, the target consistently met, the medication dosage stable, the side effects manageable. The patient reported increasing forgetfulness, attributed by everyone to normal aging. No one measured grip strength. No one timed walking speed. No one asked whether the body that arrived at the appointment had the pump capacity of the body that received the original prescription. Cascade is not theoretical. The Smith data measured this cascade's endpoint across 9 years. The mechanism connecting muscle loss to cognitive loss, peripheral pump loss driving compensatory pressure rise, medication suppressing the compensation, cerebral autoregulation failing through stiff arteries, watershed zones losing perfusion, is the engineering pathway that connects muscle loss at the periphery to cognitive loss at the center. Now, the exit point is the muscle. The carrying discussion described grip strength as a mortality predictor, the single strongest physical measurement correlating with all-cause death risk in adults over 65. The frailty paradox reveals why grip strength is a proxy for total skeletal muscle mass, the distributed pump network the heart depends on. Two measurements that take 30 seconds predict which side of the paradox you occupy. Walking speed. Mark 4 meters in a hallway, roughly the length of a kitchen or a short corridor. Time yourself at a comfortable pace, the pace you would use walking to answer the doorbell. Not hurrying, not dawdling. The pace your body defaults to when no one is watching and no destination is urgent. Under 4 seconds, a pace that feels comfortable, that requires no effort, that the body performs without thinking about balance or fatigue. And you are robust. Over 5 seconds, a pace that feels careful, that involves conscious attention to stability, that the body performs with awareness of effort, and the frailty indicators are present. Grip strength. Attempt to open a sealed glass jar with one hand. Grip strength is also the indicator that determines your position in the frailty paradox. If you need both hands, or cannot open it at all, or feel the effort in your forearm is significant rather than trivial, grip has declined below the threshold the Smith study used to classify participants as frail. The jar test is a proxy measurement of the total peripheral pump capacity your heart depends on, the distributed muscle network the frailty paradox pivots around, and then the critical medical framing. Anyone currently taking blood pressure medication must not stop without physician supervision. Abrupt cessation of antihypertensive medication carries immediate severe risks. Rebound hypertension can produce hemorrhagic stroke and myocardial infarction. The intervention is measuring frailty to determine whether the target needs recalibrating, and giving your physician the language and the self-test results to begin that conversation. The frailty test takes 30 seconds. The conversation takes 5 minutes. The prescription remains the physician's decision, informed by a variable the prescription has never previously included. Loading protocols. Prior discussions have described walking for shear stress maintenance, soleus cycling for seated vascular support, eccentric training for sarcopenia reversal. Address the root of the compensatory pressure rise rather than pharmacologically suppressing its symptom, restoring peripheral pump capacity through sustained loading. Not acute exercise, but the consistent daily progressive muscle use that reverses the annual sarcopenia rate, reduces the compensation the heart must provide. Each kilogram of muscle mass restored adds another booster pump to the distributed network. Each booster reduces the systemic pressure the heart must generate to maintain cerebral perfusion. The blood pressure drops naturally, not through pharmacological suppression of a compensatory mechanism, but through elimination of the structural deficit that made the compensation necessary. The pressure the body needed to maintain cerebral perfusion through stiff pipes without peripheral assistance decreases when the assistance returns. The medication and the target become appropriate again, not because the number changed, but because the body underneath the number recovered the infrastructure the number was derived from. The reading on the cuff is not the answer. It is a measurement of a measurement, pressure in a pipe, recorded at one point in a system that extends from the heart to the deepest capillary beds of the cerebral cortex. The question the reading cannot answer is what the body needed that pressure for, why it raised it, and what happens to the brain when the pressure it raised and needed is taken away. The body that raised the pressure was engineering a solution to a structural problem no prescription can fix. The prescription that lowered it was treating a single number on a chart. The brain, the organ that houses every memory, every skill, every relationship, every aspect of identity, sitting at the top floor of a system built from elastic pipes that stiffened, powered by auxiliary pumps that disappeared, dependent on a driving pressure that medication actively reduced, received less oxygen with each milligram of medication and each kilogram of muscle lost. The number on the monitor looked perfect. The brain behind it went quiet, slowly, silently, over months and years, and no one noticed.